I was surprised when I read the book at how, it may sound immodest, but I'm not trying to, how well it stood up in the terms of the history of it. So I was fascinatingly reading my own book the last couple of days because of you. So I appreciate that. That the definition of Tourette's, it's a syndrome, therefore it has signs and symptoms. It's not always the same in each person. We don't really agree on what the population is of people who we can diagnose. It's a part of the European diagnostic code, and Tourette's like movements are put under obsessive compulsive disorders. In the United States, they weren't until very recently because obsessive compulsive disorders was a psychiatric diagnosis, meaning organic. I think that the idea is to keep an open mind and not to look for a single cause for a complex disorder.
Welcome to The Uptick, brought to you by the New Jersey Center for Tourette Syndrome and Associated Disorders, empowering children and adults through education, advocacy, and research by sharing the stories and experiences relevant to the TS community. Welcome back to The Uptick, and thank you for joining us on this special two-part episode series, Demystifying the History of the Tourette Syndrome Diagnosis. I'm here with Dr. Howard Kushner. Dr. Kushner is an emeritus professor at Emory University, University of California, San Diego, and San Diego State University. He's a historian of medicine and neurology and has authored several books in this space, including his 1999 book, A Cursing Brain, The Histories of Tourette Syndrome. The book is well-researched and a meticulously documented account of the historical evolution of Tourette from the early 19th century to the late 20th. In this episode, we'll discuss Dr. Kushner's background as a scholar of neuroscience and history, and we'll give an overview of his book, Cursing Brain. Dr. Kushner, it's great speaking with you today.
It was nice talking to you, Michael. Thank you for reaching out to me.
Absolutely. You've done a lot of incredible research in this space, and I want to start by asking about how you first became interested in Tourette syndrome. You write in the preface of your book about how in the 80s you met a teenage neighbor of yours who had the condition, and I think our listeners would find this story interesting.
This was a time I had just finished writing a book on suicide and depression in America, and I had been trained a bit in psychoanalysis, although I no longer have the same attitude toward it as I did then. And this kid across the street, this young guy in his late teens, early 20s, would come over and stand and talk to my son and would have vocalizations, and particularly he'd have loud things. He'd make loud noises. He said this, they had Tourette syndrome. And I thought, wow, that just sounds like psychogenic disorder, not an organic disorder. So I decided to learn more about it. The more I learned, the more I began that what the etiology was is really uncertain, and that people who were diagnosed with Tourette syndrome had a very tough time of it. And so I thought this would be a good place for me to test this notion of whether it's psychogenic, organic, or whether it even might be post-infectious. Began to work there, and I began to be more and more convinced that what we call Tourette syndrome had a inflammatory or somehow or other had some sort of sequel as a result of an earlier strep infection. So I decided to write a grant so I'd learn more about this. And when I wrote the grant, I went to the Tourette Association in New York, which I didn't know about until I started looking. And they connected me with a woman named Kiesling, and she was a pediatrician at Brown University at the medical school, pediatrics. Her first name was Louise. And she said, why don't you come here and watch patients for a couple of years and see what's going on? And since I had the grant, I went to Brown Medical School, to the pediatric hospital called Memorial Hospital. And for 2 years, I observed the patients and the treatment that they were receiving. And this post-infectious theory was the one that Kiesling was particularly enamored with. So I would sit in and we'd ask the patients, all right, Dr. Kushner's writing a book on Tourette syndrome for Harvard. Would it be all right if he sat in on your interview? Everyone said yes. And so I learned a lot. I realized that you can't look at one of these disorders that are so confusing by looking at by one methodology alone. That psychological methodologies were important, organic ones, familial ones, behavioral ones, and particularly, increasingly, post-infectious ones. And I also learned that not all of the patients had the same etiology, the same experiences, the same underlying conditions that led to their presentations. I think one of the things I really learned from this is you can't talk about patients and their histories unless you actually sit there and listen to them and talk to them and follow them up. So that's how I got there. And I followed Michael, my neighbor, for the rest of the next 30 years.
Wow.
And that led me to the Tourette Association and to meeting other people with Tourette's.
Are you still involved in the Tourette space these days?
Not as much as I should be, actually. I just published a book about 3 years ago on left-handedness,
Mhm.
which actually came from the studies of Tourette syndrome, because I noticed that a lot of our patients, pediatric patients, seem more than normal of the population, more than a normal percentage, seem to be left-handed.
Hmm.
I wanted to know what was there. So that led a study of left-handedness. And turns out we're as uncertain about what left-handedness is as we are about sometimes what Tourette's was. So yeah, but I kept moving from one little aspect that I would then blow up into a bigger book. Of reading over the book again, which I haven't done in a while, I realized that I had traveled very far to get to these understandings in different countries, particularly the French, that see it as totally non-organic, and the Americans who saw it almost entirely as organic and treated with things like Naldol and other major tranquilizers. But when I got into it, the dominant theory was psychoanalytic.
Mhm.
And I talk a lot about working with the parents and the patients. Also, not only did I hang around with the patients, but I also had access to the people who had first set up the Tourette Association in Bayside, New York.
Mhm.
And they were very helpful to me. And I met the Shapiros, who were the first ones in the United States who argued this is an organic disorder, and that a psychological disorder, they said, would be a basket definition. So I had a lot of people very interested in helping me solve the mysteries of Tourette's. And now that I read this over, I realize I could make other contributions, but I'm also working on a childhood heart disease called Kawasaki disease, which I was recruited for when I was giving a talk on Tourette syndrome at the University of California, San Diego, about pediatric causes of Tourette syndrome. And afterwards, one of the pediatricians asked if I would work with her for a while on Kawasaki disease, which is totally different, but nevertheless, yeah, could use the same kinds of methodologies. So it's been quite an interesting trip for me.
No, it absolutely sounds like it. And one thing I was thinking about was how the book was published back in 99. And I'm curious, if you were to write it today, if you would change or add anything. Or I guess another way of asking this question is, if you were to come out with a new chapter for the book today, what would you like to say?
I think the evidence of the multiple etiology would be even stronger than before. There's been a lot more research and interventions through on the assumption that it's a post-encephalitic or a post-infectious disorder. So I'll give you one example. I think that would explain how to look at this. And I have published some of this in other places, even as far away as Brazil. When I first started in Tourette syndrome, the major treatment by pediatricians who weren't psychoanalytic was that there was some neurotransmitter disorder in the basal ganglia where the dopamine production is. And the treatment was to use heavy-duty meds, particularly Haldol.
Mhm.
What I found, and I did follow these up with another one of my students who wrote a book on cursing and with these patients, that it was very difficult for most of the patients, after initially doing very well with Haldol, to maintain themselves on it. In fact, I was able to interview all the first patients who were in New York who were given Haldol, and it turned out that it made them zombie-like.
Mm.
So then they would have another medication for the other drink. So all these medications, and they sort of worked, but not for everyone. And the older ones who didn't work for, sometimes would self-medicate, often, particularly with tobacco, marijuana, and alcohol. And
Mhm.
just think, if it turns out to be post-infectious, I said to myself, that would mean our intervention would be totally different. We'd stop the antibodies to strep infection, or rheumatic strep, by
Mhm.
cleaning their blood, cause plasmaresis, prophylax them on antibiotics and also aspirin. Also, we wouldn't be making them, therefore, so much dependent on drugs that, although they worked a bit, they had a lot of bad side effects for a lot of the patients. So I think if I were to write more about it, it would be this. And I think I have written some more of this in the early 1990s. When I read it, I must admit, this happens, I think, to all authors. I'd say, I don't know how I know that. Thank you for asking me to reread my own book.
Well, I was rereading it over the last couple of days in preparation for this. I mean, the idea of multiple etiologies, I think, is getting a lot more traction these days. Also, it's being informed by genetics research too, that we're finding all these different genetic profiles for people with it. And I know at Rutgers, they've identified over 500 unique genetic profiles that can lead to Tourette's. One thing I found, I don't know if you can shed any light on this or have insight into this, but the post-infectious etiology hypothesis is kind of controversial in the Tourette research world. What's the reason for that?
There's a lot of resistance. So because people are so invested in two things. One is in not making it see as psychogenic, so seeing it as organic, and therefore thinking that organic would mean that there was a substrate that's the result of heritability. And the more you learn about the way these things interact, the more you realize that they don't actually cancel each other out. So for instance, in serial strep infections, the danger comes not from the strep infection itself, from the bacteria, but from the antibodies to the bacteria, your own immune system, that attach to the basal ganglia and interfere with movements of the dopaminergic circuit. And so there can be a hereditary response to rheumatic strep. There can be several things coming together that can run in families. So I was reading over the chapter, I wrote about that. And what I noticed in the book all the way through was how persistent this finding was, that there was some relationship between rheumatic strep and in different countries. And so it always was sort of there, but no one really followed it until the 1990s, I think, was really about it. If you could interfere with the mechanism all the way through, dampen down the antibodies, then you would have an intervention, which for some, not all people have the same causes of Tourette's, not all runs in families, but for a substantial population, you'd be able to have interventions that had very small side effects. Now, some people, there's nothing else they can do. But the thing we became more worried about at Emory, but I was still working there on this, was the number of people that self-medicated, because it was so difficult to stay on the medications, even though people have titrated down a lot. And there can be a variety of outcomes to a single insult, or there can be many insults that present themselves as if they're one disease. And I think Tourette's is much, if you think about this, for a long time, Tourette syndrome was seen as a rare disease. And part of the reason for that was that obsessive compulsive disorders, which seem to be very close to Tourette's often, were excluded from the Diagnostic and Statistical Manual because they were looking for an absolutely clean example to do research on. So it would mean you could only do things on people that had certain kind of Tourette's, but only 14% of kids with Tourette's had just Tourette's, where the rest of them had a variety of things. So I think that's what I would do. I would work more with teams and follow up on some of these patients we had. I was surprised when I read the book at how, it may sound immodest, but I'm not trying to, how well it stood up in the terms of the history of it. So I was fascinatingly reading my own book the last couple of days because of you, so I appreciate that. But back to the other point is that the definition of Tourette's, it's a syndrome, therefore it has signs and symptoms. It's not always the same in each person. That we don't really agree on what the population is of people who we can diagnose. It's a part of the European Diagnostic Code, and Tourette's-like movements are put under obsessive compulsive disorders. In the United States, they weren't until very recently, because obsessive compulsive disorders was a psychiatric diagnosis, meaning organic. I think that the idea is to keep an open mind and not to look for a single cause for a complex disorder.
Your book explores a lot of the early psychoanalytic theories of Tourette. Some of the earliest scholars in the field were attributing it to bad habits or lack of self-control or bad parenting. And while a lot of that is now kind of dismissed as there is more of that organic origin to it, we are revisiting these theories to some extent. I mean, we're seeing success with habit reversal training, cognitive behavioral therapy, especially CBIT. So some of these ideas around it being self-control, the premonitory urge, how much control do I really have over that? There's a balance there. And I'm not saying any one theory is entirely correct, but it is interesting how we are revisiting some of those older psychoanalytic ways of viewing this and treating it.
And other psychological ways. I think the thing is, though, as you read over this history of attitude, there was a tendency to blame patients, right? For see them as weak or see them as exhibitionist. And some of the most famous people who treated them blame them rather than Margaret Mahler, the whole chapter. She was like the dean of Tourette syndrome. And when the patients didn't get any better, they said, well, that's a good thing, because if they cured it, then the tick itself is protection against some greater mental disorder, which is a really silly, ridiculous. But if you live in that milieu and get things published, you have to accept that set of descriptions that excludes other kinds. The story of O, which is one of the chapters. Poor guy did everything he could. He was a successful manufacturer, but Miege and Fendel nevertheless blamed him for his tics. Right? And when he tried to commit suicide, they made light of it and almost made a joke of it, which was really horrible. This guy had done everything he could. When the 1980s, when the first real uses of 1970s were for Haldol, when they were out there for the first time, people weren't blaming their patients. But remember Adam Seligman?
Oh, yeah.
Yeah, he went to the first Tourette's meeting. He became a poster person for Tourette's, and he had incredibly florid symptoms and signs. So at first he was recruited by them, but after a while he became a liability because there was this attempt to make Tourette's a wider diagnosed disorder. And so they wanted to assure parents that not every case was going to be florid. So as a result, they would shunt him off. And he actually, he died early. I had said of a heart attack, but I'm pretty sure it was something else.
Actually, on this point, you ended the article you sent me on the cursing brain with a really great statement that gets to the heart of what you're saying. You said, a well-meaning attempt to reassure parents that their diagnosed children will neither curse nor display other florid symptoms should not authorize us to neglect those who do. Love that. I mean, that's it. That hits the nail on the head there.
Yeah, and I think that's really my take-home message in my book, which is you have to have empathy with you can't blame your patients and you can't blame your failures on the patients themselves. You should keep an open mind. I mean, when you realize that we don't really even agree on the definition over time, it's hard to do a history if the definition we're talking about changed over time. So it's a perfect disorder to learn about history, multidisciplinary approaches, problem solving. I think all my work is problem-based.
I want to dive into some of the early history of Tourette. So you can teach me how to say the name. Georges Gilles de la Tourette?
Georges.
Oh, I could just say Georges.
His name is not Tourette, as people put that, but Gilles de la Tourette. It's a French noble name. Gilles, G-I-L-E-S, de Tourette is his last name, T-O-U-R. The French have incredible contempt for Americans.
One of the things he wrote was, in the early days, prognosis was very bleak. It was grim. He wrote that there is no hope of a complete cure. There's a quote, once a ticker, always a ticker. I'm grateful I was born in 1993. And even then, when I was first diagnosed, my neurologist almost did put me on Haldol. I was growing up in rural Indiana. I don't think we knew in the community I was in about some of the latest treatments being used. But I would say, okay, being born in the 90s with tics is way better than being born in the 1890s with tics. If I were born with Tourette in the late 1800s, and let's say I had access to some of the best researchers and physicians of the time, what would treatment look like for me? If it really believed that there's no complete cure, would the focus just be on helping me develop my willpower to overcome tics, or what would treatment even look like?
Well, as you pointed out, it's to make a definition of Tourette syndrome, because immediately when the typology was laid out, some of Charcot's other students attacked it, said no, it was wrong. But the thing is that the treatment at that point was hopeless because the definition of the disorder was we would get worse and worse, like the Marquis did here. But the trouble with that conclusion was that the patients themselves, he didn't have, in the study, they didn't have enough patients that lived long enough, not that they were not alive, but the entire article is based on people who were in their 20s.
Wow.
Except Dampierre, who, as I point out, no one ever saw anyhow. The treatment would be, you'd be forced between and among these people, but the strongest voice that emerged from the 1890s by Miege and Fendel was that this disorder was a result of the lack of self-control of the people who demonstrated these clinical signs. So that wouldn't be very helpful at all, because when doctors can't solve a problem, again, they often attack the people supposed to be treating them. Miege and Fendel, they also represent, as the whole Charcot group does, late 19th century neurology. But in some of that neurology, they don't have any good interventions. So, for instance, Miege and Fendel, Miege himself, he wrote a second doctorate in France. And so Miege wrote his second doctorate on the maladie de la Juif errant, which is, I guess you read it, it's in the book, about blaming the Jews for creating this, except given where we live in right now, it may not be.
I noticed that too. That was eye-opening to me, was the early anti-Semitism in the history of Tourette. I did not know that until I read your book. That was frightening to read.
This was science, the idea that you went from doctor to doctor, and something was wrong with you, question your physician, right? There was a disease at this time called la maladie de papier, which was that people would come to see their physicians, their neurologists, with little lists of all their symptoms and signs. And this was seen as a disease rather than as an attempt to get at the disorder itself. This kind of obsessive compulsive disorder.
It is. And I mean, this early idea in the 1800s that the condition was degenerative, even Tourette had noted about it. He wrote that it started in early childhood. You get these tics. And then my understanding is the kind of assumption was that it ultimately evolves into coprolalia and gets worse over life. Is that fair to say?
That was the theory, and echolalia. So if you couldn't show
Echolalia.
things, then you might put it in a different category. It wasn't necessarily a better category. Different. So the degeneration argument that you inherited a weakened set of genes, if your grandfather was an alcoholic, then you would be an alcoholic, or you'd be. This again was this idea that it was inherited, but there wasn't enough data to come to these conclusions. It's interesting when you look at the treatment at some of these other patients that I lay out, they don't really fit the diagnostic category. I think that's the one lesson I learned from history, which is, and this is true of handedness or other things, is that you can't make claims of things over time if you don't have the data to show you the examples of them. So.
Oh, and it also underscores the point of like multiple Tourette syndromes. Like we can't just write one succinct description that fits everybody. One thing I was curious about was in the early days, in the 1800s, the emphasis on coprolalia and that being the big thing that it was believed to evolve into, that and echolalia. Is it fair to say that that early characterization of this condition is ultimately what kind of paved the way for the future of Tourette being labeled, associated with this swearing condition, this kind of blurting out obscenities? Is it fair to say that started in the 1800s with some of the early ways that we characterized it?
But it got strongest in the 1940s under Margaret Mahler. Mahler, we say, well, do you have to have this clinical sign? So if they didn't have echolalia or coprolalia, she would argue that they're repressing it, right, because of masturbation. Right?
Wow. Okay.
And if the child in the examining room, and she followed them, didn't display coprolalia or echolalia, she'd still say that's a sign of even deeper disorder. It's almost laughable if it weren't so sad. She was convinced that all these things were repressed sexuality. Of course, her whole attitude towards sexuality has changed so much that so it was a disorder to be a masturbator.
Wow.
They did masturbation. That showed that they were really masturbating.
Well, I mean, I imagine this underpinned a lot of how they explained a lot of conditions, not just this. Like a lot of it came down to this theme,
especially psychoanalytic pediatrics, blaming the parents and early childhood conflict, were all ascribed to a disorder rather than to a weakened ego. But at the same time, they would also admit there was an organic substrate. So both these things.
Like it's organic, but also it's your fault, or it's your bad habits.
Right. So if you can't find this behavior, then that's evidence that underlying behavior for the tics and vocalizations, and that's even more evidence that it's there. No matter how they cut it, they would always blame the situation and the patients. One of the kids at the end of the chapter, I talk on Mahler, he says, I don't know what you're saying. It's a sex thing. I'm not thinking about sex. I just want to get rid of my tics. You're doing and he said, you're doing witchcraft.
One of the things that stood out to me was how even in the early days, like Miege and Fendel observed that their patients with tics, the tics would often subside when they were engrossed in something they found interesting. The tics would dissipate. Can you talk about that? Because that is so true. And we talk about that a lot today. It's part of how we coach people. It's find your passions, find hobbies, find things that that really engross you, because that is a coping mechanism. It's one of the closest things to a cure that we have. And it was enlightening to me to learn that was such an early discovery or an early observation, was that this did happen when they were really engrossed in something.
Yeah, I think this ability to have a different focus and work as an actor, for instance, even learning roles from plays and things, which would be difficult just sitting around, but it's very interesting why that takes place. And yet it's sometimes when you have people who are able to defer a tic for a while, that sometimes later it comes back when they're no longer doing that. And I think that's a really good area of research for someone to look at why they wax and wane to begin with. But the best clinical approach would be what waxes and wanes. And again, it's infectious diseases and the antibody infectious diseases. So that's there. They weren't in the 1920s, depending where you look. You don't really have much sympathy or much discussion of its waning because they don't follow patient long enough. The one patient O, who has an array of everything, they had the theory of explaining it before they even had the case itself. His case was used to justify their theory. What's interesting, I think, is whatever the dominant medical, particularly psychiatric theory of the time is, it always becomes the causes for Tourette syndrome. So the causes keep changing with the changing of, say, of psychiatry. And now we live in a world where we look at more post-infectious disorders and where we look more at other kinds of organic disorders. I don't think we've reached the end of our explanations of Tourette syndrome by any means, I guess is what I mean.
So I would agree, yeah.
It's a very interesting thing to study. I wish more people would do it.
I do too, you and me both. Tourette really came to the public forefront in the late 20th century, beginning with the emergence of the Tourette Syndrome Association. You talk about this in your book. In 1972, there was a group of New York City area parents. They had children with this condition. They started a support group. That was the origin of the organization, now the largest in the world for Tourette support and research and advocacy. And it sounds like in the early days of the TSA, they were really intent on replacing these dominant psychoanalytic frameworks that tied the condition to bad parenting, lack of discipline, early childhood sexual conflict. Is that a fair characterization?
Yeah, I think it's exactly right. I think the only thing I'd add, which doesn't detract from what you said, is that the parents would feel bad after a while when they had their kids on some meds, particularly Haldol, because their children, there was a lot of rapid weight gain. The kids were unhappy. There's that. There's still the parental guilt, but certainly there was a real concerted effort by these people from New York City and Shapiro's to get their story out. And they were very open to me. I mean, they invited me to stay with them because they really wanted to come up with some explanation. But there were some very sad things that happened then too that I didn't write about, which is the problem of siblings of people with Tourette syndrome or any other kind of pediatric psychiatric disorder. It's very difficult on the siblings as well. And sometimes the parents focus more on one than the other. I don't have any solution for that except to find the cure for the disorder. So they deserve a lot of credit. If you ask me what the most important thing in treatment would be, I would say support groups for kids with kids doing the support. Kids with Tourette's talking to one another, that really is helpful. And no, looking at many films and then introducing myself to many of the patients, they would all tell me that the most useful thing that they had was the chance to talk to other people and experience it. So when they were younger and it might have gotten worse over time, the signs and symptoms, they were more prepared. And also peer help is really important.
Oh, it's huge. I mean, now that the Tourette Association has a youth ambassador program rising, like they have a number of, I think there's a junior youth ambassador program as well. The organization this podcast is with, NJCTS, has a youth advocate program kind of similar. And that's the point of it. We take young people with this condition, teach them to be advocates, but you're also getting them in front of other young people with it. And I went through these programs growing up and I found that was getting to meet other people with it was so liberating and did so much for my own confidence. Because with the numbers on it, I mean, yeah, we are learning it's more common than we once thought, but still a lot of kids are growing up not meeting someone else with it. It can be very isolating.
No, I think that's exactly right. If you ask yourself another question, how come there's so few Tourette's diagnoses earlier and say the first half of the 20th century and so many more in the second half of the 20th century? Is there actually something what creates more? Is it ascertainment bias? In other words, we now have a label for this as a spectrum disorder from mild to very, very severe. Is that just it? Or is there something else? Is there an actual real increase? When I worked on another disorder, Kawasaki disease, that was the question I had to answer. Was there actually more Kawasaki disease or was there more ascertainment of it? And I think that's a good thing to always ask yourself when you're looking at these sorts of things.
Well, ADHD too. I mean, that one with the diagnosis of ADHD really exploding in recent decades. I've heard it there as well come up, that question.
Yeah, well, what happens when you add obsessive compulsive disorders, other kinds of focus disorders with other Tourette's, you get a much larger number.
Hmm.
Maybe people also are less interested in trying to hide the fact that their kids have Tourette's and much more open about it, which makes it easier for everyone. I mean, I had a patient who would say whenever he got an airplane, there's a bomb on the plane, which
Hmm.
is not a good thing to say. But I think we've become much more accustomed to it, and we see a bigger spectrum of what constitutes Tourette syndrome and involuntary speech and other things.
Can you talk a little bit about the contributions of the Shapiros in reframing this condition as organic?
There were quite heroes, actually. He kept running into the fact that these patients, he also read the literature and noticed that in Europe, there were a lot of people that were tying Tourette syndrome or the signs and symptoms of Tourette's to a wider population because they included obsessive compulsive behaviors and ADHD. And so if you add those in, and all of a sudden you have more, and also you have more people willing to talk about it. And
Mhm.
since it's much more well known, so the Shapiros, they were at Cornell Hospital. They kept insisting this was organic, and essentially he couldn't get his article published following these patients. So finally, the only place he could get that famous Now paper about Tourette syndrome can be treated with Haldol, he couldn't get it published in the United States, so it had to be published in the British Journal of Psychiatry.
Wow.
So that's the other thing. The politics of medicine and subcategories has a lot to do with what goes on. People are very much attached to their theories.
Yeah, that is
So
human nature.
I had met Shapiro just as he was dying. I just got to town and was supposed to interview him. And when I was at their house, he got the phone call that he had prostate cancer.
Oh,
But they were very nice to me. They wanted to get their story out and did. He really gave the foundation, the Tourette's Foundation organizations, really their first legitimacy. Later on, they didn't all get along so well. Mrs. Dr. Shapiro was very generous with her time and efforts.
and it sounds like one of the best pieces of evidence that we had for Tourette being this organic biological etiology came from research by the Shapiros and others showing that medications like Haldol could help people. I mean, albeit with some nasty side effects and not fit for everybody.
Yeah, some people could tolerate it for much longer. Now, of course, the dose is much lower, and so the toleration is better. But it's very difficult for older people with Tourette's, as you know. And some have done remarkably well, and others have had more problems. And the cultural context in which they experience it, I think, makes a big difference.
I'm going to ask a question that is kind of impossible to answer, but some of it we've touched on already. If you were to predict the next 50 years of Tourette, frameworks, research, how we characterize it, how we describe it, in 50 years, how do you think this situation will look?
Well, I can only predict the past because I'm
Right. So I said it's an impossible question.
Yeah, but I would say what's going to be taken much more seriously are post-infectious disorders and multifaceted disorders. The drugs we have now, there's an intervention, a therapeutic intervention, where you can go into the basal ganglia and change the on-off switches in the basal ganglia. Deep brain.
Oh, DBS, yeah.
And it works.
Mm-hmm.
I've seen incredible examples of where it works for kids who couldn't walk off the pavement without jumping down 5 times or banging their head, that this operation worked. It also works for Parkinsonian patients at the opposite direction. It's the same structure, but one you want to increase dopamine, the other you want to decrease it. So anything that will be able to make the ganglia, the brain will operate without having to do serious interventions, it's going to be a big difference. And so I think there'll be more neurobiology and more immunology and getting the collaboration between these different fields, which much more happens now. Then I think that's going to open it much more and open lots of possibilities. So I think it'll be better. Also, our diagnostic tools are better, but sometimes not making a diagnosis can be as valuable as making a diagnosis.
Can you elaborate on that? That's an interesting point.
There was a time in which, especially in the late 70s and 80s, where people would identify, I am Tourette syndrome.
Mm.
And then fighting against it, they would But that sometimes would make them into the disease. Their whole life was around the disease. And as you pointed out with the examples of people who can do something else and their tics go away, at least for that time period, means there's a lot more they can do. So I think that's going to make a bigger difference when so much of our life is medicalized to begin with. I think there are ways that current interventions in neurobiology over time. DBS is also now used for obsessive compulsive disorders.
I read about that. Yeah. There's been some cases
A colleague of mine actually at that time at Emory. And there's a guy named Michael Oken. I don't know if you run into him in Florida, who's really good. He does what's called gamma knife interventions. He was also at Emory at the time.
And I've also seen new research coming out with like TMS, transcranial magnetic stimulation for tics. I am not familiar with the efficacy of that. I know that's being studied. Also, cannabinoid region of our brain. There's also a number of anecdotal reports of patients finding benefit with marijuana, THC.
We know it works because they were using it.
I was going to bring that up. Yeah, you mentioned that.
And our patients, our 16 patients that we're following, adult patients, they had heavy marijuana use. It seemed to work pretty well, whereas alcohol and cigarette smoking does not work as well. But on the other hand, initially, sometimes cigarette smoking, although there's all kinds of downsides to it, I'm not advocating it. Sometimes it could get somebody through a period that's difficult. And maybe we could figure out ways to use nicotine in a more efficient way than we are.
The coping.
So I wish I could answer your question about the future, but one thing for sure is I won't be here 50 years from now, but write to me.
Well, your contributions will still be felt. I mean, you put together an incredible book that just outlines the whole history from the 1800s to late 1900s. I do recommend it to our listeners who are looking to understand who were these initial doctors and the person our condition is named after. What was his contribution? It's a really well written book.
Thank you very much. Thank you also for asking me to talk about it because it forced me to go back and look at it. And one of the things I found reading the book, I've been interested lately in stuttering. And a lot of Tourette's patients and people diagnosed were, in fact, stutterers from time to time. We looked at that very much in terms of handedness as well. There's a lot more to do that other people can do, move from where I was to what we've learned in the last 25 years.
One last question. As someone who's seen many patients with this condition, what advice do you have for people with it? I always like to end my interviews with a question like this. What would you tell a Tourette patient, especially adults with it?
Well, I don't know. I'd have to have each case is different, or so it's hard to say. But the one thing I would recommend was interaction with other people with Tourette's sometimes, especially for young kids. Some people do really well on medications. Some of the TPS operations we did are amazing. So I think the movement's going to be more sophisticated understanding of the interaction of genetics and genes and infectious disease. Much more collaboration work will be done. And that's true every place. So it should be an exciting time to work on this and maybe to find some other interventions, but not hiding it and not feeling guilty. Would be where I'd start. And I certainly would encourage youth support groups, which I see there's many of now.
That is something we've done great work with, the TAA and JCTS, other Tourette organizations. There's summer camps now you can go to. I volunteer every August for the Tim Howard Leadership Academy, where we take high school students with tics and we teach them how to make that transition into adulthood. Driving, getting your first job with tics. Do I disclose in a job interview? What should first responders know about tics if I'm in an accident? We train them on these things, and I've seen that be so empowering for these students. And it's such a critical age, too, where you're 14 to 17 years old and starting to grapple with the emergence of adulthood. That is a time with lots of questions and challenges, and people need that support and support from others who get it, other young people with tics, adults who've had it for many years, getting it from people who have lived it.
No, I think that's true. You don't want to romanticize disease. Some people do, and you don't want to ignore it. If you asked me in 1992 when you were born what the future would be, I think it's been remarkable what's taken over and people of understanding, opening, and willingness to find this more widely. So I think having these institutions like the summer camp and other sorts of things, having annual meetings, these are all very helpful. Local chapters were a good thing at first, but they also sometimes would have a downside.
Well, now with the internet, I mean, people are finding support groups online and we can do so much more remotely too, connecting people.
Yes, we're able to do it today.
There is so much more to discuss. Join us for part 2 on Tuesday, March 12th for the rest of our discussion. We'll dive into the contributions of Georges Gilles de la Tourette and how the Tourette diagnosis evolved through various medical and psychological models over the 19th and 20th centuries. You don't want to miss this. Thank you for listening to The Uptick, brought to you by the New Jersey Center for Tourette Syndrome and Associated Disorders, empowering you to stretch the boundaries to live your best life. The NJ Center for Tourette Syndrome and Associated Disorders, NJCTS, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on this podcast. We do not endorse any recommendation or opinion made by any guest, nor do we advocate any treatment.